start by acknowledging some people who helped with some of the ideas and figures for this talk. So some of the figures that you'll see have been made by Maria Martignoni. She's a postdoc with, minimize something. She's a postdoc who was funded by CanMod during her studies. And also some of the figures and ideas are by Zara Mohammadi. She is a postdoc with Mathematics for Public Health who recently completed her postdoc. Just let me know if you can't hear, okay. And I'll try to, I know it's a bit noise in the hallway right now. Also wanted to acknowledge some collaborators, Francis Inoki from Memorial University, Julian Areno, Bilal Hussain, Monica Kojakara, Brian Gass, JC Laredo Osti, James Watmouth, and Steve Walker. Funding is from CanMod, Mathematics for Public Health, Omni Reunus, NSERC through the Emerging Infectious Disease Modeling Program, and some data support and funding from the Newfoundland and Labrador Center for Health Information. So I want to talk about 5 different aspects of how we can do modeling to support regions implementing an elimination strategy. I'll talk about model fitting, scenario modeling, theory to support elimination, data and analysis needs, and knowledge translation needs. So I want to start with some terminology, just to be precise about what we mean by elimination and how it contrasts with other approaches to infection control during a pandemic. So elimination is reduction to 0 incidents in a given area. So the number of new cases that are reported is 0. And oftentimes this might just be with respect to travel-related cases. Eradication is similar to elimination, but it's on a global scale. So the goal is to reduce incidence to 0 throughout the world. Suppression means that incidence is low, and mitigation aims to control an outbreak. So usually that means to specify control with respect to what. Usually there's some kind of goal associated with mitigation. So during the pandemic, an example of that goal might have been to keep hospitalizations due to COVID-19 below hospital capacity. I'll also talk about importations. Importations are when an infected person is reported and they have a history of travel. I'll talk about travel-related cases. And so these are both the importations and the close contact of an importation. It was important to distinguish between these type of cases during the pandemic in Newfoundland and Labrador, as there were restrictions to self-isolate, and so there was not a lot of occurrences of spread from these individuals that were travel-related cases to the community, and so they needed to be treated separately. This is what the pandemic looked like in Atlantic Canada and the territories. So the key is given in the Labrador panel, and the darkest shading and below the solid line are the importations. These are reported cases where there's a known history of travel. There's a lighter shading, and so those are the close contacts of the importations. These might be family members who were self-isolating with the traveler. And then anytime you see a shaded region that isn't bounded by any kind of line, that's representing community cases. So you see a community outbreak occurring in Newfoundland and Labrador in February 2021. And this distinguishing feature of Atlantic Canada and the territories is that elimination was occurring, especially if you consider just elimination in the community, so no community cases. So the percentages that you see are the percentage of cases that are travel related of all cases that are reported daily. So for Newfoundland and Labrador, of all the cases that are reported each day, 77% of them were travel related cases. And you see like very high number in Prince Edward Island, mostly only travel related cases that were reported, 91% of reported daily cases being travel related. The other aspect of elimination is that not only these numbers are high, so most of the cases being reported are travel related, but you have these periods where you have absolutely no community cases being reported. So in Newfoundland and Labrador, from July 2020 until February 2021, very few, if any, community cases reported at all. Everything is travel related. And then you have a community outbreak. And during that time, the community spread overwhelms the importations. And so you flip between the situation where either all of your reported cases are travel related or all of your reported cases are importations. And this is the pattern that's seen in Nova Scotia as well, and Prince Edward Island, very little community spread reported at all. New Brunswick is a bit different. You can see like there's these regions where you have community cases, and so that was a bit different than some of the other Atlantic Canada provinces. And then for the Northwest Territories and the Yukon, they just reported very few cases overall, either in the community or being travel related. So this is what the data is like. It has this signature, especially for the top 3 provinces where you're seeing elimination, and you're reporting periods with no community cases, and then periods with community cases, and then periods with no community cases again. And so I would argue that Atlantic Canada and the territories have novel epidemiology. They also have novel needs in terms of the questions that they're going to be asking during a pandemic. The approach to modeling these regions needs to be, we need to develop novel methods, which I'll try to show during this talk. And in addition, I think these regions have perhaps been under-supported with modeling. So this is an R script that pulls the number of PubMed articles that meet certain search criteria. And so this is, if you search for COVID-19 and modeling, then you can see you get different numbers of modeling articles. You get different hits there. For Newfoundland and Labrador, 19. And then this relationship is dependent on the number of people in the province. So if I take the log to the base 10 of the number of people in the province and plot out the relationship, you see like a strong kind of correlation between number of papers and population size. And then the size of the dot is the ratio of the number of articles to the population size. So you see Newfoundland and Labrador with a really small dot. So the number of articles per capita is very, very small. And I would argue that we need to pay more attention to these regions because of their novel needs and because there have been few articles that mention them. So in terms of models, to do modeling to support regions that are implementing elimination, I think there's 3 types of models that you need: an importation model, a community spread model, and a spillover model. So perhaps you're familiar with the first 2. And the third one, I think, is the most important one if you're going to do modeling to support regions implementing elimination. It's the one that connects your importation model with your community spread model. So first, let's take a look at importation model. Just going to grab a drink. So I think there is a real need for importation models. They can have an important role for real-time forecasting for regions that are implementing elimination. And during the pandemic, I did have an importation model running. It was taking the number of new cases reported in each of the Canadian provinces and doing a Poisson regression to try and predict the number of travel-related cases that would be appearing in Newfoundland and Labrador. So this is the real-time forecast. The blue region is where there's a forecast. This email is sent on December 21st. It's right before like the blue line just skyrockets. So the model was doing nothing for a long time. It was just saying like 1 travel-related case a day. And then with the emergence of the Omicron variant, predicted like a lot of travel-related cases arriving in Newfoundland and Labrador. So that was a prediction in real time. And later we validate it with the actual data of travel-related cases that you can see over here. So this Poisson regression is actually only fit with data in the gray region. So all the data in the white region is out of sample. So we stopped training the model in June 2021 and then predict travel-related cases. I think what's amazing is it actually predicts a skyrocketing number of travel-related cases due to the Omicron variant. And that was really driven by the reporting of more cases in other provinces of Canada, particularly, I think, Nova Scotia. So I want to talk about importation models, and a lot of times travel volume is a variable that's connected with travel-related cases. So this is on the left, the travel volume as reported on travel declaration forms. These are forms that people are required to fill in during the pandemic when they enter Newfoundland and Labrador. So that from that, we can figure out the number of travelers that are arriving of domestic origin or international origin. So international origin in gray. And we also took the average for each month. So you see these lines that are kind of representing the average across each month. So you can see how over time there's an increase, and you can also see that there's more domestic travelers entering Newfoundland and Labrador during the pandemic than international. So this is just the raw data, because here I'm just trying to get a general sense of whether there is a relationship between travel volume and travel-related cases. So travel-related cases are on the right. And you sort of see a bit of an increase over time. This is going through to June 2021. So that's what the data looks like in terms of travel-related cases and travel volume. We're going to try and use more variables in addition to travel volume to try and predict travel-related cases for our importation model. We'll do several versions of the importation model. So this is the structure of the mechanistic model. There's a couple of philosophical approaches or there's a spectrum of philosophical approaches, I guess, to modeling importations. So at one end, you would have very statistical models, and I'm going to describe the features of a very mechanistic approach to predicting travel-related cases. So you have individuals are going to arrive in Newfoundland and Labrador, and their place of origin is either going to be a Canadian province or international. And we do the distinction at that level because that's how the cases get reported, is from Canada or from international. So the model considers the probability of when you first have symptoms. That's parameterized from a source in the literature. We assume that 69% of exposed travelers develop symptoms. 75% of symptomatic travelers will still travel anyway. The exposure period here, this is all with respect to the travel date. So we consider individuals that are possibly exposed 14 days prior to travel. There could be a pre-departure test and when some of the restrictions are in place. And for the test, the probability of a true positive, like there's a probability associated that depending on the number of days since exposure. So the test is done 2 days before travel. And then in order to be reported as a travel-related case, you would need to have some post-arrival testing. And sometimes there's a delay between the testing and the reporting. So here, this is showing an example of post-arrival test completed D days after arrival and reported 1 day later. So we're going to try and predict the number of travel-related cases of domestic and international origin, and we're trying to build in everything we know about the process that generates those reported travel-related cases. So one component is the travel volume, and we consider 4 different sources to try and get information on travel volume. We had information from the International Air Transport Authority. That's data source number 1. It only covers the time period of before the pandemic. It only covers travel by air, and it excludes crew in terms of their reported travel volumes. we had the travel declaration forms from Newfoundland and Labrador. These were only occurring during the pandemic, and you were excluded from having to fill these out if you were a resident of Newfoundland and Labrador, if you were crew on the arriving vehicle, and there was also some other exempt travelers. There's frontier count data. This is when you enter Canada from an international port. You're required to complete declaration form. So this frontier count data, it only considers people from international origins. And so there's 3 different sources of travel data, but they all have exempt groups. So in order to really get a sense for what the arriving travel volume is, we needed to augment some of that information. For example, how many people are arriving by vehicle versus air. So those estimates we got from reports by the Department of Tourism, Culture, Arts and Recreation from Newfoundland and Labrador. And so we kind of put everything together and we were able to estimate travel volume. So red is the estimated travel volume, which includes corrections for some of the limitations for the different data sources that I just mentioned. The bars here are different types of travel restrictions that occurred during the pandemic in Newfoundland and Labrador. And the green line and the pink line and the blue line are if you just take some of those data, like the International Aviation Transport Authority data, so that's only air data. So that's what that looks like. That was also only pre-pandemic. There's also a period where we don't really have any good data in the middle there, gray. And so overall, this shows a decrease in travel volume by 81.6%. And on the right, we break that down into of Canadian origin or international origin, because that is important for validating with the data. Not only do we see a decrease in travel volume during the pandemic, but we also see a shift in terms of the composition of province of origin during the pandemic. And notably, we see about a 10% decrease in the percentage of Canadian travelers, or sorry, the percentage of all travelers originating from Quebec, going from 14% to 4.7%, while we see a 10% or about a 10% increase in Alberta. Before the pandemic, 7% of travelers were originating from Alberta, but during the pandemic, 16% originating from Alberta. So a shift in where travelers are coming from during the pandemic. And then for the mechanistic model, I mentioned that to be reported as a travel-related case, you need to be tested. So just to say that a lot of detail went into this aspect, where we considered all the different federal and provincial requirements for arriving travelers to be tested on the left. And then on the right, there was exposure notifications at certain times, and individuals were requested to come in for testing, and that also got considered in the mechanistic model. So we considered these, that was called the epidemiological model number 7. And then we have our response variables, Canadian travel-related cases and international travel-related cases. And we compared a number of different ways of modeling this. So that was a very mechanistic way that I just outlined. But if you remember, I said originally I was doing a Poisson regression, a statistical model, and doing quite a good job of predicting travel-related cases. So we did a number of different statistical models that considered estimated travel volume and infection prevalence, or just infection prevalence for each of the different provinces. Or we took travel volume multiplied by infection prevalence and aggregated across Canada and thought, well, maybe that would be sufficient. So there's a number of different approaches, or there's 6 different statistical models here with different number of variables, and an epidemiological model. These have different number of parameters. We use ACA-EK information criteria corrected for low, so AICC. And then we have strong evidence here that the best model is one where you take the travel volume from each of the provinces, multiply by infection prevalence. And if you do a statistical model that way, you would explain 55% of the variance. it doesn't really make sense to aggregate infection prevalence across Canada and multiply by travel volume from Canada. Then your statistical model is it's a bit simplistic. You could do better at predicting travel-related cases if you didn't do that simplification. And for the epidemiological model, there's only one parameter that's fit, but it only explains 15% of the variation in travel-related cases. So while that model might be attractive because it has a lot of the realism that was actually occurring in terms of accuracy in predicting the travel-related cases, it's not, it's much worse than just going with a statistical approach. In terms of trying to predict travel-related cases from international origin, the best model explained only 5% of the variation in travel-related cases of international origin. So overall, we did not find that we had the ability to reliably predict travel-related cases of international origin. These are just some pictures of what the predictions look like. So for the epidemiological model, this is reported travel-related cases each day. It has these spikes in it, and that's corresponding to when there were exposure notifications, meaning that people could be reported as travel-related cases after that, as they were asked to go in for testing. This is the reported travel-related cases of international or Canadian origin. In terms of the fraction of travel-related cases that are of Canadian origin, that becomes higher over time, fewer from international origin. And in Newfoundland and Labrador, rotational workers are individuals that reside in Newfoundland and Labrador but work in other provinces, and that's probably where a lot of the travel-related cases are coming from. So then we compare, that's just the model predictions. If we aggregate the predictions over each month, we can compare to the reported. So the reported is the yellow line here for Canada. Remember I said my best model was a statistical model that multiplied travel volume by infection prevalence and explained 55% of the variance. That's the green bars here. So this is, you're seeing the difference between the predictions and the actual model. And then the epidemiological model, it's worse because it only explains 16% of the variance. But here you can see it's mostly from March 21st to May 21st when the epidemiological model, the blue bars, does much worse. And then this is on the right, on panel D, you're seeing the inability of the model and that all of those different models that we considered might give you some ideas for how to approach importation modeling, depending on exactly what you're trying to do. The other aspect of the other type of model that you want is a community spread model. And so you're probably familiar with these. These are your susceptible, infected, recovered, SIR type models, SEIR, SAIR, all those combinations. So here individuals are categorized based on their infection status, whether they're susceptible, whether they've been exposed, and then the type of infection that they have, asymptomatic, pre-symptomatic, severe infection. This affects how likely they are to transmit the infection, but also can correspond to some variables of interest, such as the chance of dying or being hospitalized. And so we can do those types of models for Newfoundland and Labrador as well. This is an example of during a community outbreak in Mount Pearl. This happened in February 2021. And so we can do the model fitting to the community outbreak. And we can also consider scenarios here. So the green is the data. This was an outbreak of the alpha variant. And then we also do some scenarios for how the outbreak might have looked if it had involved a different variant. So original variant is in the gray, and that's not causing very many cases. Alpha variant in the green. And then Delta variant in the blue. And I think this is an old version of the figure because actually it should be the BA1 variant that's causing the most cases. So I think if I go back to actual paper, we'll see that the Omicron variant is the one that causes the most cases. Okay, so we have community spread model, but for doing modeling to support regions implementing an elimination strategy, one of the most important models is a model that connects your importations to community spread. And this is one idea of how to do that. I think this is an area where we need to have some innovation and come up with new and better models. So the idea for connecting travel-related cases to community cases here is just to consider this process to be binomially distributed. And so the chance that you have a spillover, you can imagine that as every traveler, every travel-related case who's infected, that's a trial. And P is the probability of that trial being successful. So it's the probability that traveler initiates a community case. And then you might calculate the probability, the expected number of spillovers by taking the expectation of the binomial distribution. So you have the number of travel-related cases, and this is indexed by vaccination status and variant. So you have the number of travel-related cases, people infected with a specific variant and a specific vaccination status, and then the probability of successfully infecting the community member there's a probability associated with each of those traveler types. And if you sum across all vaccination and variant types, then you get the expected number of spillovers, assuming that spillovers follow a binomial distribution. So this is a graph. This is showing what it actually looks like. So expected weekly spillovers, what I just outlined, is shown in panel D. I have some of the data going into those N and P parameters in the top rows. So the number of importations over time helps you figure out what that N is, like the number of travel-related cases, and they all have some probability P of spilling over. So it's broken down by variant proportion. And then the probability of a symptomatic infection in a community member changes over time as individuals get vaccinated. So this is pharmaceutical interventions. So this is like, given that you're infected with a different variant type, then what's the chance that you would get a symptomatic infection? And so as individuals get vaccinated, it's harder to get infected given exposure to the Alpha and Delta variants. And then also the community measures. So even if a traveler violates quarantine, if there's a lot of community non-pharmaceutical interventions, then community members are less likely to get infected. So there's non-pharmaceutical interventions represented by a stringency index. So all of those top three things go into a model that predicts the expected number of spillovers. In the bottom, I have plotted like where there actually are spillovers. So in February 2021, there's a spillover of the Alpha variant. May, June, there's a spillover of the Delta variant in Lewisport. I don't know if there is a very high risk of spillover of Omicron variant in December, and that does actually happen. But other than that, I don't know that there's a very good relationship between spillovers actually occurring and them being likely to occur based on travel volume and everything else that went into the model. You see step 1 and step 2 are aspects of the reopening program in Newfoundland and Labrador, where restrictions are being rolled back, and you can see quite a high risk of a community outbreak at that time, but none really reported. So that's the different models that we have, and now I want to talk about how to support regions that are having elimination by fitting the right models. So this is a model that is fit by Zara Mohammadi, also working with Steve Walker. And this is the model fit in blue to the data for Newfoundland and Labrador. Again, the dark shading is travel-related cases. The light shading is community outbreaks. The model that's fit here, I call it the importation community spread switch model. Because sometimes you're just fitting an importation model and other times you're fitting a community spread model. And so the dashed lines here represent where we actually make the initial condition for the community spread model so that community spread can actually happen. So that happens early on. We have an outbreak at the funeral home, a community outbreak. And so we let the community spread model go, but then when the number of infected individuals gets low in the compartmental model, we set the number of infected individuals in the community equal to 0. And that's going to mean that we can't have community spread happening anymore. Even if we have the, people mixing a lot in the community such that theoretically you could have community spread, there isn't any community spread because there's no infected individuals in that compartment to seed a community outbreak. So then after that outbreak dies off, we're fitting mostly just an importation model until we know we have a community outbreak in February. So we allow for the community spread model to have an initial condition such that we have 1 infected individual. And we do the same thing. So we switch between the importation model and the community spread model being active. So the data is the incidence of travel-related cases. The dark shading is travel-related cases. The light shading is community cases. We include a variable that is travelers in isolation. So 10 days before a reported community outbreak, we briefly allow the rate that an isolating traveler infects a susceptible community member to be positive, and that was represented by the vertical dashed line. At all the times, we don't allow for that connection between the importation and community spread model. And when infectious individuals in the community is less than a small threshold, we set that equal to 0. So that's basically what the importation community spread model is. The rationale for needing the importation switch model, importation community spread switch model, is the following. So this is just showing how we can maybe go about this the wrong way, why we need the switch model. So imagine you have a stochastic simulation, and on any day you could have a community outbreak. This is what's shown here with simulation 22 and simulation 99. So you're imagining you have this stochastic simulation. Those are 2 different types of dynamics that maybe we could have seen in Newfoundland and Labrador. This is running over 2 years. We're seeing for simulation 22, 1, 2, 3, 4, 5, 6 community outbreaks. We have travel-related cases down the bottom. A not good approach to modeling a region that's implementing elimination strategy would be to treat the day that the community outbreak starts as a random variable and then average across those. If you did that, you would get the black line. And this is showing 100 simulations and just how you would get the wrong inference if you took the average of those. Simulation 22, simulation 29, and 98 others just like those. You completely misrepresent the dynamics. You think that you have a constant low level of cases, where in actuality you have a number of distinct outbreaks and periods with no cases. So we get undesirable model dynamics when we treat the start date of a community outbreak as being uncertain. And I think the problem, we also get undesirable dynamics if we allow there to be a fractional number of individuals arising from importations, and if we expose them to a community where you have a reproduction number that's bigger than 1. This is the second point, is undesirable model dynamics that can arise from compartmental models. So in compartmental models, you can have fractional numbers of individuals, and that can diverge from reality, where you can not have more than, or you cannot have less than 1 person that's infected. And this particularly becomes a problem when you have the community spread rate bigger than 1. If you allow for importations of fractional individuals to happen, then the model is going to predict a community outbreak, but in reality, you won't have one because if the model's allowing for fractional importation, in practice, most of the time, that's going to be no individual that's imported. So the importation community spread model aims to overcome the limitations of doing a regular stochastic approach or a regular compartmental approach. So to do scenario modeling for regions that are implementing an elimination strategy, you want to first generate the dates for the community outbreaks, and you can have RFT bigger than 1. Well, the rules that go into the simulation that I'm showing is that RFT is for the community spread rate is bigger than 1, except when community cases are bigger than 100, and then you implement restrictions. So there's really only like a few days in there for the red one, simulation 99. We've got 1, 2, 3, 4, 4 community outbreaks that are suppressed. So there's 4 periods of time when I have community spread rate with corresponding to R is less than 1. All other times R is bigger than 1, representing the idea that you can relax restrictions between community outbreaks. So if you're going to do scenario modeling under this framework, good things to do are calculate at the end of multiple realizations the average number of community outbreaks, the average size of the community outbreak, and the average number of days without community cases. Bad ideas are to take the average prevalence at a given time. I showed that on the previous slide. And you also don't want to take the dates as being particularly meaningful. We just think that 4 outbreaks might happen, but we don't want to say which date they are, because that changes with every simulation. To do the scenario modeling, you need a spillover model. So this is one idea for how you might do it. So in the black in the top, you've got travel-related cases, and we assume that every travel-related case was infectious for 5 days before they were reported. And so if you make that assumption, then you get the green graph, which is reflecting what potential there is for an infectious traveler to enter the community. To do the spillover model, you need to come up with dates for when the spillovers happen. And so that's one idea, that travelers are infectious for 5 days before they're reported as a case. And then you say, for example, I want to have 10 spillover events, and then you can figure out the days for when those might be using the inverse cumulative method. So the bottom, I have the green curve, but I've represented as cumulative. And, so it's got a very steep slope towards the end, and that's because there's more travelers in self-isolation that are infected. So I choose a random number between 0 and 1, and then that helps me figure out what's a plausible date for when a spillover could happen. Doing it like this is pretty simple, but also a good idea, because you don't really want to have in your scenarios the possibility of having a spillover when actually you don't have any travel-related cases at all. So this helps to make a strong connection between travel-related cases and spillovers. You could also make it much more complicated, because the spillover depends not only on the number of travelers, but also the variance, the pharmaceutical interventions, the non-pharmaceutical interventions. And so you could make a spillover model as we did previously, and get the dates that way using that same cumulative approach. So this is, now I want to talk about theory to support the implementation of elimination. This is a graph by Maria Martignoni, and the idea is that elimination can happen if the time between importations is large and the time in which it takes to get rid of the community cases is relatively short. So in the top, you see elimination strategy, and there's the blue people, which are importations, and they happen pretty far apart. So you're able to get rid of the community outbreak with these red severe restrictions, and then you can have mild restrictions until the next importation comes. Down the bottom, the importations come kind of frequently relative to how long it takes to get rid of a community outbreak. So the community spread rate, RFT. So we just have mitigation, and we're saying that maybe you want to do moderate restrictions in that case. So we can kind of take those two variables and plot them out in space and think about where do we have the different strategies or the different epidemiological dynamics occurring. So the variables are the number of days between community outbreaks and the community spread rate when you implement the restrictions to try and get rid of infection in the community. So if you have many days between community outbreaks, and if you have a very small RFT, you're in this region to the bottom right, and that means that you'll have elimination happening. And if you aren't able to get RFT less than 1, then you'll just be doing mitigation because you have exponential growth, and so you're managing for trying to stay below hospital capacity. If you want to keep cases low, as in the case of suppression, then you need to be able to get RFT less than 1, and if it's not a lot less than 1 and importation rate is high, then you're in this suppression region. So this is to say that different regions are going to have different abilities to get the community spread rate low, and they're going to have different characteristics of when community outbreaks are occurring. Some other theory that is needed to support elimination. So I think we need to be able to give better guidelines of when can strict non-pharmaceutical interventions be eased. The World Health Organization defined a COVID-19 outbreak as over 2 generation intervals after the last case. So early on, this was 14 days. So we had to wait 28 days after the last reported case before you could ease, or before you could define the outbreak as over. And in Newfoundland and Labrador, that seemed to correspond with decisions around releasing strict MPIs. So I think we need to, 28 days is quite a long time, and 14 days, I think it was later. So I think we need to come up with a more confident way to assess when the outbreak is over and we can ease restrictions. There is a paper that has a good idea for doing that. This one at the bottom, deciphering early warning signals of SARS-CoV-2 elimination. We need to come up with methods for estimating the community spread rate. Could be in terms of the number of secondary infections, average number of secondary infections generated by the average infected individual here, so RFT, in low incidence regions, so regions that have few cases. And again, that same paper has a good idea. To support regions implementing elimination, we need to have clear criteria for when travel bubbles can be formed. Some of the ideas for doing so were on slide 16, and also there's a paper that has some nice modeling as well. So when importations are such a driver of the risk to the community, then rotational workers can be a vaccine priority group. So these are individuals that work in other provinces and or internationally. And so another idea, we had done this during the pandemic, but I think we could do it again in the framework of the spillover model. We need a specific theory for reopening plans, and that was something that we did in 2003 paper. Another area of need is to come up for justification for having travel restrictions for provinces that particularly have a lot of vulnerable individuals, or even regions within a province that have a lot of vulnerable individuals. And that's something that my honor student is working on a little bit. Okay, so in terms of needs, I think to support during a pandemic, regions implementing an elimination strategy, it would help to have data reported, delineated in terms of travel-related cases and community cases, because these arise from different mechanisms and have very different risks associated with spreading. So this is an important heterogeneity that should be reported in data. We also need to develop spillover models, and one way to go about that would be to do a statistical analysis of spillover risk. So I have down the bottom, like when the community outbreaks happened in Newfoundland and Labrador, but what variables can help us predict spillover? That's something that could be approached statistically. And of course, we should try to get more regions than just Newfoundland and Labrador in order to do this statistical analysis. But this is an area of need and something that would be good if it was investigated. We need methods to estimate community spread rates when there is no community spread. So when you don't have any infected individuals in the community, you can have a high contact rate. And if infection gets in, then it will take off very quickly. But how do you estimate that contact rate when there isn't any infected individuals in the community? So we need to come up with methods to do that, to support regions that don't have any community cases, because that's a data source to estimate that parameter that is missing. This could be estimated from contact surveys or cell phone data. And we also could possibly try to make inferences from regions where there is community spread if we had a good understanding of regional factors that affect community spread. There's also needs for knowledge translation. I think modelers need to better communicate that Atlantic Canada and the territories have novel modeling needs, and also that infection control strategies are not necessarily the same everywhere. And also that modeling complexity has trade-offs. Oftentimes people will want to put a lot of complexity into the models, and I think we need to communicate better what some of the trade-offs are with doing that. Realism is good, but modelers know why we don't always do the most realistic thing. And we need to communicate that with decision makers and people who are trying to interpret models, critique models. Models also need to use fitting methods for regions that are implementing elimination strategies, like the appropriate ones, like the switch model that I mentioned, and also use the appropriate framework for counterfactual simulation. I mean, this is how I think of the question about model complexity trade-offs. Depending what your question is, then you're going to need to do a really realistic job of some part of your model. So I think for regions that are implementing elimination, I would want to do like a really good job of the importation model and the spillover model, and estimating parameters related to community spread in my community, how much more transmissible is a different variant. I would put a lot of effort into those aspects, because I think my conclusions are going to be very sensitive to those. And then there are some other things that are like good, but maybe not good for my specific question. And I think it's okay to just like ignore those things or treat them at a very high level. So for example, implementation of capacity limits in rural communities, or like distinguishing between the brand of vaccine that people want. Like, I guess you could criticize the models for not considering that, but I don't know that putting that in is where I would spend my time. Like, I would rather like spend a lot of time on the things that are really important than an equal amount of time on everything. So to summarize, in a region implementing elimination, decision makers will want to know how non-pharmaceutical interventions impact cases, but I want to know that when there aren't any community cases. And this is going to be really hard, because the community spread parameters are really difficult to estimate because there is no infection in the community. And it's a bit of a catch-22, because if there's no community cases and you say, if you do these non-pharmaceutical interventions, then you're still going to have no community cases, that seems pretty unremarkable. Or if we say that if you relax some MPIs, then you are going to have some community cases, then that seems like it's very, very dramatic, because you've gone from a case of no community cases to community cases. For regions implementing an elimination strategy, you want to consider different decision variables. Oftentimes, as modelers, we're reporting the number of infected individuals, but for regions implementing elimination strategies, I think it's better to report things like the spillover risk, the expected number of community outbreaks over some long period, or the expected number of days when you can ease restrictions because there's no community cases. We need to come up with thoughtful ways to link our importation models to community spread models. And I've given some examples here, but I think this is a really open area. The spillover model is important because it's the link between the data that you have, which is travel-related cases, and what you're interested in, which is how that it will affect the community and all the structure that the community has, such as the vaccination levels or the certain non-pharmaceutical interventions that are in place. And we need models that can recommend elimination, because in some circumstances, I don't think elimination is the strategy in all cases, but we need models that have the ability to recommend elimination as the best strategy. We need to come up with criteria for reopening and travel bubbles. And I think this is necessary to support decision makers. I think it's also important from the perspective of health equity, because I think one of the variables that tips in favor of recommending elimination is that if the population has a lot of vulnerable groups. And so I think this is a way that modelers can contribute to support public health in the future. All right, so that's the end of my talk. Thanks everyone for being here, and